All right, good afternoon. Welcome to today's session, Mental Health is Not a Crime. My name is Dr. Ben Miller, and I am the Chief Strategy Officer for Wellbeing Trust, a national foundation focused on advancing the mental, social, and spiritual health of the nation. Alongside the Kennedy Forum, Inseparable, American Psychological Association, National Alliance of Mental Illness, and the Education Developmental Center, welcome to the second of 5 sessions on mental health policy. If you like mental health policy, you have found yourself in the right place. If you're new to this series, we kicked it off last week with a session entitled Understanding the Problem, Crafting the Right Response, which saw a conversation between NIMH Director Dr. Josh Gordon, former Congressman Patrick Kennedy, founder of the Kennedy Forum, and the Director of the National Action Alliance for Suicide Prevention, Colleen Carr. We also had a few special guests that popped in along the way, including Representative Napolitano and Representative Katko, who are the co-chairs of the House Mental Health Caucus. The opening session laid the groundwork for how our country can embrace a more comprehensive response to mental health and suicide prevention during and after COVID-19. If you want to see more about what they talked about, you can find it on the YouTube channel. We can send you the link. You can also go to the nationalmentalhealthresponse.org to see the 6 priority areas that we're talking about. So before I turn it over to today's moderator and session team, let me briefly offer up 2 quick reminders. One, if you missed last week or you want to share today's presentation, we'll pop the link in the sidebar to where we're posting the recorded webinars. Second, as I mentioned, this is a series on policy briefings with today focused on crisis. Next week will be Rethinking Workforce, a session that I think is going to be pretty amazing. That session is scheduled for April 9th, 12 to 1 Eastern. You can register. We can make sure that the links are shared everywhere. You could probably find it. We'll put it in the sidebar as well. We're recording each of these sessions to post on the YouTube channel. So with that, we hope that you could join us for the subsequent questions. Each of these 5 sessions that you can see here on the screen have been carefully curated to bring the best thought leaders and national experts to the table to discuss concrete ways we can address our nation's mental health and addiction crisis. And that's why we're here today, to talk about crisis. So let me get out of the way, turn it over to today's moderator, Joy Brunson Insabuga. She's a licensed marriage and family therapist, a licensed clinical addiction specialist, and certified clinical supervisor, and currently the Vice President of Southeast Operations for RI International, overseeing North Carolina and Louisiana programs. Joy, thanks so much for your leadership. I know we've got a great crew ready to get going today, so I will turn the session over to you.
Thank you so much, Ben. I just want to say welcome everyone to our panel today. We are very excited to be here and to be able to talk about this really important topic. So welcome to the panel, Mental Health is Not a Crime. I just want to talk a little bit about the logistics of today's panel. We do have 5 experts that will be talking from different perspectives around this topic. And then at the end, we will save time for question and answer. If you would like to put your questions in the chat, I'll be moderating the chat. And then at the end, we'll be selecting questions that will be presented to our panelists to give some answers on. So we're very excited about that. I would like to introduce our speakers. Just quickly, we do have Chief Murphy Paul. Chief Paul began his career in Baton Rouge Police Department, and after retiring from the Louisiana State Police as Deputy Superintendent with more than 26 years in law enforcement, he has held management responsibilities in various areas of law enforcement, which included the oversight of gaming operations, criminal and special investigations, as well as the State Fusion Center. We are very excited to have Chief Paul with us today. And then we also have Dr. Richard Mckeon. Dr. Richard Mckeon received his PhD in clinical psychology from the University of Arizona and a master's of public health in health administration from Columbia University. He is currently chief for the Suicide Prevention Branch in the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, where he oversees all branch suicide prevention activities, including the Garrett Lee Smith Tribal Youth Suicide Prevention and Campus Suicide Prevention Grant programs. We are very excited to have him here as well. We have Dr. Matthew Goldman will be our third speaker today. Dr. Matthew Goldman is the Medical Director for Comprehensive Crisis Services in San Francisco Department of Public Health, and he is a volunteer, a clinical assistant professor in the UCSF Department of Psychiatry and Behavioral Sciences. From 2018 to 2019, he was a policy fellow in the Office of the Chief Medical Officer at the Substance Abuse and Mental Health Services Administration through the Health and Aging Policy Fellowship and the Congressional Fellowship Program. We are very happy to have him as our third speaker today. Our fourth speaker will be Tondra Miles. Tondra Miles is an ordained minister, a community activist, peer counselor, veteran, subject matter expert in mental health, untreated trauma, a faith-based approach to substance abuse recovery, and sought after counseling for community-based and system approaches. She promotes mental health awareness and rehabilitation with sharing her life experiences being in recovery from addiction for over 36 years, a suicide survivor, victim of childhood and adult sexual abuse, and diagnosis of PTSD. We're very excited to have Tondra Miles as our fourth speaker today. And then our fifth and final speaker will be Ron Bruno. Ron Bruno serves as the Executive Director of CIT International. Ron is the founding board member of the corporation and previously served as the corporation's second vice president. Ron is an appointed member of the Interdepartmental Serious Mental Illness Coordinating Committee, a federal committee that reports to the United States Congress to make recommendations to better coordinate the administration of mental health services. Ron brings to this position and this appointment a 25-year law enforcement career where he specialized in crisis response. So I'm gonna set the stage for you for what the panelists will be talking about over the next hour. So what we're looking at, if we can move to the next slide. So today, if you have a medical emergency, you know to call 911, and then 911 will triage for you, send an ambulance out to you, and then that ambulance will then go to the emergency department that will accept you. This happens across the country, and every time it happens the exact same way. Everyone receives care. Next slide, please. If you are in a behavioral health crisis, it is not exactly the same way. Of course, we know that if we are in an emergency, we call 911. And 911 will send a law enforcement officer out to this behavioral health crisis and to look to address whatever is going on. You can have someone who is in psychosis or experiencing suicidal thoughts, and a law enforcement officer will be dispatched to the scene. The crisis pathway is a little bit different. There is only one place really for this law enforcement officer to take someone, and that is the emergency department. That is not necessarily set up to address a behavioral health crisis or the mental health need. So the officer is there with the individual, working with them or sitting with them, which is what they call wall time. And that wall time takes the officer away from their public safety responsibilities. And so they're there and waiting with the individual. Unfortunately, the officer, because of the wall time, because of the time it takes to really take someone to an emergency room and being there, they also have the option of booking someone on nuanced crimes and taking them to jail because they feel like this person needs to be off of the streets. This is the crisis pathway for individuals when they call 911 because there aren't any other options or they don't know the number in their area. This is the current crisis flow. Next slide, please. We also know that when law enforcement responds to someone in crisis, it can be very traumatizing and triggering for an individual, especially in the communities of color. And we also know that the detention centers are the places that are really see a high number of individuals of color, and the hospitals are not necessarily set up to meet their need. And so what we have today is really looking at law enforcement involvement in this crisis pathway and this behavioral health crisis need. What happens to individuals when they're at the ED, and how long it takes for someone to be able to actually get the care that they need. You will hear from our next 5 speakers about the solutions or ideas that are coming into play: law enforcement involvement, lived experience, 988, and national structures. You will hear about legislation and also research and data around what's coming, what's out there, and what opportunities we have. So without further ado, I would like to pass it along to Chief Murphy Paul.
Can you hear me now?
Yes, we can hear you.
I apologize. I'm sorry. I was having a technical difficulty. First of all, I want to say thank you for the opportunity to speak today on this critical issue facing communities all across America. You know, from a law enforcement perspective, what we're talking about today is really the sanctity of all human life. And that's important when we look at law enforcement's response today. You know, the lives of the people that we protect and serve, but also the lives of our police officers. As public servants, we should always be mindful that the preservation of life should always be at the heart of policing in America. And today, policing in America is at a significant moment. And there are so many opportunities that have been presented for us to reimagine policing in America, where we focus on training, our tactics, our policy, but also on our hearts and minds, on the core ideals of policing. You know, when we look back almost 2 centuries ago, a gentleman by the name of Sir Robert Peel started these principles. He talked about our ability to perform our duties is dependent upon the public approval of police actions. And we must secure the willing cooperation of the public in voluntary observance of the law to be able to secure and maintain the respect of the public. And the recent incidents in America, like the death of George Floyd, has made its way to communities all across America. And what it's done is it's agitated scars, created anger in neighborhoods, it's presented fear, anxiety. And then we have the COVID crisis, the challenges of uncertainty, the stress, and economic hardship. And all of these incidents not only brought trauma into our communities, but it also exacerbates existing suffering, pain, and distress that are already happening in our communities. And we know as law enforcement leaders, we cannot arrest our way out of this problem, and we also can't do it alone. We need the community by our side and engage in partners. You know, as police officers, we are in the people business, and we do this by building relationships and by helping in the collective healing process. And one way to do that is the reason that we're here today, and that's to support crisis services all across America. You know, police professionals must take the lead in working with the local healthcare professionals on this issue. We must acknowledge that we're not always the smartest ones in the room on this topic, and we have to become active listeners and practice the art of fellowship if we're really going to get this right this time, because we are facing some serious, challenging times in our community, and mental health crisis that we're facing is real in America, is very real. And this requires us to rethink how we approach calls for services involving persons experiencing a mental health crisis. Now, just here in the city of Baton Rouge, we began our crisis intervention training with our police officers. All police officers have to go through the mandatory 40 hours in training. And as we begin to build on this program and train our officers on what to look for and giving them the tools, we also realized that that in itself was not enough. So we were fortunate right here in Baton Rouge, where the people of Baton Rouge listened to our mayor, they listened to our district attorney, our sheriff, and myself, and other mental health service leaders and community leaders. And we actually went out there and asked them to approve a tax. It was a 1.5 millage property tax that was passed here in Baton Rouge, cost about $1.50 per month on average for the homeowner, generates about $6 million for 10 years. But what we've looked at based on that data and that tax is going to generate about $55 million in savings over the life of this 10-year tax. Now that's important because what it did, it helped us create the Bridge Center for Hope right here in Baton Rouge. And what the Bridge Center for Hope has done, we now for the first time have a service providing the appropriate care to individuals who are experiencing a mental health crisis here in Baton Rouge, those who have substance abuse, who come into contact with law enforcement, whether it's a caregivers can call, a 911 call, and our police officers who are responding to call. But before the Bridge Center for Hope, there was no other alternative. The only other alternatives we had were prison and emergency room. Now we agree that both of those systems have value in their own right, but not the kind that a mental health stabilization has provided this community. The Bridge Center is providing the care that families need and have been needing for quite some time. You know, when we tracked our response time on mental health concerns for calls for services, we were looking at times from 4 hours to 12 hours. I want you to think about that. 4 to 12 hours is the amount of time our police officers were spending on calls for service involving someone who was experiencing a mental health crisis. As of today, those calls are down less than 4 minutes. 4 minutes. So the police officer, when he comes into contact with somebody who suffers from a mental health crisis, he's able to now take that person to the Bridge Center for Hope, and their response time is less than 4 minutes, getting them in and out. And that police officer can now go back on the road and continue patrolling the communities, as well as providing reduction in times to other calls for service. So since the Bridge Center opened, February 11th is when it opened, you know, the first 32 days, we had about 80 drop-offs from law enforcement, 80. So when you look at the 80 drop-offs in the times that I just previously mentioned, that translates to hundreds of manpower savings, and we can redirect those resources to other areas. So we know that it's working here in the city of Baton Rouge. We've only been, going on a couple of months in, but we are excited about the potential and how we know it's going to continue to help us reduce crime here in the city of Baton Rouge. And one of the things it's done for us, you know, all across America, police departments like Baton Rouge are facing recruiting challenges. Their vacancy numbers are higher than normal. Many police departments are required to do more with less. So to have the availability of those resources is very, very appreciated. But law enforcement leaders should always be exploring on how we can advance our profession. And looking at ways to improve the mental health crisis for service is just one key area in our complex profession. So when we examine calls for services and incidents involving a person who's experiencing a mental health crisis, what we see are significant potentials for reducing use of force incidents, while also increasing officer safety. So I'll conclude with this, because it's important that we understand that listening to those folks who are involved in public safety, who are involved in our community, is critical if we're going to continue to build down those bridges in community police relations. You know, when we talk about reform in other professions, it's welcomed, it's encouraged, it's celebrated. When we talk about technology industry, transportation industry, medical field, social media industry, communication industry, I can go on, and we say, wow, look at all that change. But when we mention reform, it simply means to improve or make better what is unsatisfactory. Crisis response service are needed today, and it's necessary as we continue to build our trust in policing. and it's welcome, and we're excited about it here. And I look forward to continue engaging in conversations just like this, so we continue to provide those services, because we know when we look at the data doesn't lie. We can do better, and we must do better if we're going to continue working. And I mean crisis response services. I applaud your effort with all our efforts in policing to try to train our officers. Nothing compares to the training that these crisis response teams are providing right now in our communities. Thank you.
Hello, this is Dr. Richard Mckeon from the Substance Abuse and Mental Health Services Administration. I am pleased to be with you today to talk about some of the developments, particularly from SAMHSA's perspective, regarding mental health crisis services, and particularly as we move toward universal availability of 988 as the new suicide prevention and mental health crisis number. Can we move to the next slide? And of course, I also want to take a moment to thank the organizers for this panel today, as well as my co-presenters and the expertise and lived experience that they bring to this. What I'll be expressing does not necessarily represent the views or opinions of SAMHSA or the U.S. Department of Health and Human Services. Next slide. So it's important to be aware of there are numerous noteworthy developments in mental health crisis services that are going on currently, and which together present a unique opportunity, in fact, a once-in-a-generation opportunity to improve mental health crisis services across the country. So let me mention a couple of them. One is by order of the Federal Communications Commission, as well as in the National Suicide Hotline Designation Act, 988 is in the process of being implemented all across the country as the new National Suicide Prevention and Mental Health Crisis number. Okay, and the every telecom provider, every landline, every cell phone, every voice over internet must make that available by July 16th, 2022. For many, it's available, right now. You have a T-Mobile or a Verizon cell phone. Actually, 988 works now, but it won't be universally available across the country until July 2022. By order of the FCC, the way 988 will work is that it will be routed to the existing structure of the National Suicide Prevention Lifeline. Last year, the Lifeline answered over 2.2 million calls, as well as additional chats and texts. And we anticipate that that number is going to increase significantly with universal availability of 988. In addition, this past December, a 5% set aside to SAMHSA's mental health block grant was initiated for crisis services. And so that's important. So for the first time, every state has this 5% requirement. It's modeled on the existing set aside for early onset psychosis. SAMHSA has issued national guidelines for behavioral health crisis care. I'll talk a little bit more about that in a moment. Also, there has been a major expansion of SAMHSA's certified community behavioral health clinics. This is important from two different perspectives. One is that these certified community behavioral health clinics have requirements to be providing crisis services. They are also very important as a place to receive rapid referrals from crisis services. so that if somebody is identified, for example, as being at risk, having suicidal thoughts, they can get into, for example, outpatient care quickly. So you can move on to the next slide. So SAMHSA has issued national guidelines for behavioral health crisis services. And this document, which is available on the SAMHSA website, includes those guidelines, but also includes a number of different papers, applications to youth, on financing, on technology, and a number of different issues about how mental health crisis services can move forward to meet needs and to save lives. You can move on to the next slide. So SAMHSA's guidelines are based on the notion that there are three core elements to community mental health crisis services that every community needs to have access to, in our view. This is not necessarily a comprehensive array of all crisis services, each of which has important roles, but we regard these as being core. And these three are have been highlighted in what's called the Crisis Now model, which was created by the National Action Alliance for Suicide Prevention. So one is a call center hub. There are currently 184 crisis call centers who answer calls through the National Suicide Prevention Lifeline, as well as the three Veterans Crisis Line centers that are operated by the Veterans Administration, and that can be accessed by pressing 1. That feature of being able to press 1 for veterans care will remain during the transition and after the transition to 988. A second is mobile crisis outreach services. The idea that not only will there always be someone available to talk to you, but that there will be someone who can be available to come to you as well when that is the need. And then the third are crisis facilities, crisis receiving and stabilization facilities, alternatives to going to the hospital that can provide rapid access and short-term care that can avert, in many instances, the need for psychiatric hospitalization. And you see that picture to your right of an airplane and the phrase air traffic control. You may wonder what that means. Well, you know, if you were to fly from Washington, D.C. to Los Angeles, there would never be a time when there wasn't an air traffic controller who knew where that plane was and would have responsibility for tracking on that. But we routinely lose people in the lethal gaps in our mental health crisis systems. The idea of this air traffic control crisis call center hub is that it would have the responsibility for staying in contact and knowing where people in crisis, whether they're at risk for suicide or other significant mental health issues, were in the system and didn't get lost in the cracks. Next slide. I also wanted to mention that these same elements were mentioned as being an important part of the Surgeon General's call to action on suicide prevention that was released in January. There were 5 crisis care recommendations, and you can see how these mirror SAMHSA's recommendations, including the development and use of statewide or regional crisis service hubs, mobile crisis teams, crisis receiving and stabilization facilities, ensuring safe care transitions for patients at risk. And that's that air traffic control notion of staying in contact with people at risk, and ensuring adequate crisis infrastructure to support implementation of the national 988 number. Next slide, please. So what you can see here is the notion of a crisis system actually working as a system, where a person will call the 988 number. And in our judgment and what our experience is in working with folks across the country, is that about 80% of those can be resolved on the telephone. Some, of course, will need face-to-face contact, and that's where mobile teams will come in. And we think 70% of those could be resolved in the field, right? And then those that cannot can go to crisis receiving and stabilization units in the community. And that there is community-based care and post-crisis connection and wraparound. Next slide. So I mentioned the National Suicide Hotline Designation Act. There are several reports to Congress that are mandated by that, an FCC report on geolocation. SAMHSA and VA have a joint report on the resources need to implement 988 operationally and effectively. A SAMHSA report on training and access for high-risk populations. That legislation also authorized states and localities to institute fees similar to 911 funding. And 15 states have now introduced legislation on 988, and Utah and Virginia have both signed into law 988 bills. Next slide. Here are some of the key issues. One is making sure there's adequate capacity. Just yesterday, the FCC issued a further notice of proposed rulemaking on texting to 988. This is analogous to the efforts to encourage texting to 911. The need for the kind of coordinated mental health system that we were just describing, and the need for collaboration between 988 and 911 on the federal, state, and local level. If we do these things, there's an opportunity to reduce unnecessary police involvement, unnecessary EMS involvement, and emergency room boarding, and making sure that police, EMS, and emergency rooms are only used when they are needed. Next slide. So as said, the Crisis Call Hub plays an important role of this. You can, in the interest of time, please go to the next slide. So this is to make the point that in an era, we can track a package halfway around the world. It should be unacceptable in the United States of America for us to lose track for people at risk for suicide or other mental health conditions between the fragmented components of our mental health crisis systems. Next slide. And that's why we think it's time for a national mental health system that doesn't have to be exactly like 911, but 911 for the past half century has become a system that people rely on all across the country. We believe it's possible that 988 can also become exactly that, and we have a unique opportunity. I believe that's my last slide. That's my contact information, and I am now done.
Thank you so much, Dr. Mckeon, and to all the panelists. Really excited about being here and about this opportunity to present to you all. So I'm Matt Goldman. I am Medical Director for a Crisis Service in the San Francisco Department of Public Health. I'm also on volunteer clinical faculty at UCSF, and I serve as a member of the Council on Advocacy and Government Relations for the American Psychiatric Association, and really appreciate the opportunity to join you today. I'm going to be speaking to you about research in behavioral health crisis services, but before I do that, I also just want to briefly speak from my experience as a clinician. So I'm a psychiatrist. I've worked in a lot of different settings. I've worked in psych emergency, inpatient, outpatient settings, and for the last 5 years, I've gotten to work as a clinician on a mobile crisis team in a couple different areas. And there's nothing like working in crisis services. They say a picture is worth 1,000 words, but a field visit to somebody's home is worth 1,000,000. It's very useful for me as a clinician to get to be there in somebody's own environment, to understand what their life is like, to be able to see with my own eyes what their living environment is like. It helps with the clinical assessment. And also it's so valuable to the person who I'm coming to serve. They're in their own safe, comfortable environment. They might have the support systems that they need right there in the room with us. And it's such a different experience for the clients as compared to being in a whitewashed, fluorescent lit emergency department waiting for hours to be seen. So just wanted to share that before getting into some of the research. You can go to the next slide, please. Our behavioral health systems are failing us. Suicide and overdose deaths are increasing. Suicides increased over 33% since 1999, and over 48,000 Americans died by suicide in 2018 alone, and 20 times as many adults attempted suicide. Over 81,000 drug overdose deaths occurred in the United States in the 12 months ending in May 2020. And carceral system involvement is also an issue. Over 2 million people with serious mental illness are booked into jail each year. The prevalence of mental health and substance use disorders in jails and prisons is 3 to 4 times that of the general population. And people with mental illness are incarcerated for twice as long, and few receive the needed treatment. Emergency department boarding, also an issue. People with mental health and substance use disorders have longer wait times, increasing emergency department utilization. And there's a lack of outpatient mental health access and capacity. Only 50% of adults with suicidal ideation, plans, or attempts report any contact with any mental health services in the previous year. And you see in this slide, right at the middle is disparity. So these problems do not affect all individuals equally. There are major disparities in how these issues affect our population. So for example, in Maryland, suicides during the COVID-19 pandemic halved in the white population, but doubled among Blacks. Black people account for 41% of those receiving mental health services in the LA County jails, even though they represent only 30% of the overall jail population, which of course itself is overrepresentative of the population at large. Longer emergency department wait times have been seen in non-Hispanic Black populations as compared to non-Hispanic whites. And between 2004 and 2011, significant disparities have increased among people identifying as Black, Latinx, and Asian compared with whites in terms of use of any mental health care, outpatient care, and any psychotropic medication in the last year. So there's clearly a need for parity in mental health crisis services, the same as for general health emergencies. Next slide, please. So I'm going to go through the different components of a crisis service as Dr. Mckeon described. So first, starting with call centers, there's good evidence for crisis call centers. When the National Suicide Prevention Lifeline, that's 1-800-273-TALK, which soon will become 988. When it was first implemented in the mid-2000s, there were some good studies that showed decreased suicidality during calls, as reported by callers. 1/3 to 1/2 of callers connected with mental health referrals following a call. And callers said that a follow-up initiative that was implemented really with SAMHSA's leadership stopped 80% from killing themselves and kept 90% safe. Next slide. Mobile crisis teams also have evidence to support their use. There have been studies that show increase in community-based mental health services, reduced post-crisis hospitalizations, reduced emergency department utilization, and also significant cost savings due to diversion from inpatient admissions because of mobile crisis. Next slide. Also, crisis facilities have evidence. So some of the conventional, existing models for crisis facilities include things like the START model, which showed voluntary acute care in non-hospital settings could be achieved at lower costs. Empath units, which show decreased emergency department costs, decreased emergency department boarding, and shorter length of stay. Acute residential models, which have been shown to be equivalent to inpatient with high satisfaction among clients served. And also peer-staffed crisis respite, which show decreased hospitalizations and expenditures. And there's growing evidence for no wrong door crisis receiving centers, which are really at the backbone of the Crisis Now model. And I'll be sharing at the end of my talk a little bit of hot off the press data showing some of the benefit of that type of crisis facility. Next slide. Finally, there's also evidence for post-crisis wraparound. So regardless of the type of crisis service, whether we're talking about call centers, mobile teams, or receiving facilities, those individuals in crisis also need to be connected to services often. There's the moment of crisis, but then there's also a need for outpatient linkage and what I refer to as post-crisis wraparound. And there's a lot of different evidence-based approaches for how to achieve that. Structured telephone follow-up and repeated follow-up contacts, transitional psychiatry clinics, scheduling appointments for patients prior to discharge, in-house case management, and also even postcard interventions, sending somebody a postcard after a crisis encounter, just to check in with them and have another point of contact. Next slide. So what I'm showing here is some of that recent data. So this is a study that we're doing in Arizona. Arizona is a real national leader in the crisis services that they've been able to assemble in their state. They have a really robust model and they pay for many of their services using Medicaid. So using Access Medicaid claims data, and this was a study in collaboration with ARIA International and also the Arizona State University Center for Health Information and Research. Using Medicaid claims, we looked at a one-year sample, so from 2017 to 2018 among all adults. What we did is we examined if a mobile crisis facility, emergency department, or inpatient service was followed by a higher intensity service within 72 hours. And what we found was that among the 126,000 total episodes of people in mental health crisis in the state of Arizona in that 1 year, 41% remained in crisis-only settings. So those 14,000 in mobile crisis only, 34,000 or so in crisis facilities only, and then about 4,300 that went from mobile crisis to crisis facility. That 41% of all of those crisis episodes were able to be maintained in those crisis type settings, rather than needing to go to an emergency department or an inpatient setting. And so what that really highlights is that a system that has a lot of these components built out can effectively maintain clients in settings that are lower cost, will have shorter stays, and also are in less restrictive settings, meaning that they're not involuntary as much, they're more in a person's own home environment or a more familiar environment. Next slide. And then finally, we also found that when you look, for example, at just those episodes that initiated with mobile crisis, so you see those that are in the orange box here, 48.4%, so about half of mobile crisis initiated episodes, have no further acute mental health services within 72 hours. So you can see 15% end up going from mobile crisis to a facility, 16% from mobile crisis to an emergency department, and 20% of those that start with mobile crisis do ultimately end up in an inpatient setting. So certainly these are acute cases that mobile crisis is going to serve, but they're able to resolve about about half of those visits in just the mobile crisis unit itself. So basically resolving in the field. So all of this goes to show, first of all, that research is really important. I'll always give a plug for making sure to include data collection and evaluation to be able to really tell the story of the successes of these programs. And also, I think that this research highlights that crisis services are very well positioned to advance better quality care, equity, lower costs, person-centered care and less restrictive environments, and also alternatives to law enforcement and to the carceral system. So with that, it's my great pleasure to pass the baton over to an amazing person and a wonderful, effective, brilliant advocate, Tanja Miles.
Thank you so much, and good evening, everybody. Good afternoon. I am so excited about this conversation and to be on a panel with such amazing people who really, really, really had the passion to do this work and to bring about this change, because change has been a long time coming, but I'm grateful that I can get to actually be a part of it and see it. I wake up every day like I'm on a mission. I'm a veteran. I love this country. I love my community. I'm a pastor. I'm a wife. I'm a peer support specialist. There are many things that I am, and I'm grateful that I am alive to do this. And this is personal for me. My mom, the first time I had to end up calling law enforcement was for my mom who was about to drink herself to death. We didn't know what to do. And someone actually told me, you can, go and get her OPC, PEC. And that was about, I guess, 30 something years ago. And so when that actually happened, someone walked me through it, but I was still nervous. And so I remember law enforcement coming to pick up my mom that day. And I remember them putting her in the back of that police car, which was really traumatic for an 18-year-old girl to see, but it helped save my mom's life. I have an uncle who I am the primary caregiver. He's 78 years old. He has HIV, bipolar, schizophrenia. And he was the uncle that people would always tell me, Tanja, you're going to be crazy just like your Uncle Larry. And I grew up scared of my Uncle Larry because my Uncle Larry was the person in our family who we didn't talk about who nobody knew what was going on, but we knew that he stayed in and out of group homes and jail. He had a mental health diagnosis that nobody talked about, because in the African American community, you don't talk about mental health. That's not our issue. That's those people's issue. And so the fact that today I'm his caregiver is simply amazing. In 2019, I had to get my uncle OPC 10 times in 1 year. And even with me knowing the resources and knowing a lot of people, but being that family member, each time that I know that law enforcement was going to be involved, I was still skeptical about how that was going to play out. And I'll tell you about that later. I've been in this business for many years. My husband and I opened up the first licensed faith-based treatment in the state of Louisiana in 2004. And I never forget, somebody asked me one day, Tanja, so why is it that y'all have so many white people in y'all program? Where are all the Black people? And I'm like, that's a good question. And what I realized is that a lot of people that did not look like me were going straight to East Baton Rouge Parish Prison, and their white counterparts or peers were actually given the choice to maybe go and get help. And so then we kind of, changed our way of how we begin to do work in the community. And we started doing more volunteers in East Baton Rouge Parish, so we could go in, talk to those people who had issues with addiction or mental health, and then maybe be that warm handoff for them to come and see us once they got out. Because again, I knew something was not right to say that was so different. The interaction is different. I've been on wellness calls where family members have called, law enforcement or 911 and said, hey, my family member's having a mental health episode and we don't know what to do. And so when I do tell that family member, look, go ahead and call 911, tell them you want to do a wellness check. And for people of color, they're like, Tanja, we don't want to do that. That's not cool. They have trauma because of the relationships already of people of color and law enforcement. And look, I get that, but I, assure them like, no, it's going to be different. It's not going to be like that. They're just going to go and check on them. Meet them over there. I'll meet you over there. And even being in those different spaces, I noticed that it was a different interaction when it came from people of color than people who were not. And I'm like, we have to change that. And so being able to talk to CIT programs here in East Baton Rouge Parish, what Chief Murphy Paul was talking about, I'm grateful that I get to talk about my lived experience, to put a name and a face with mental illness. Hopefully when law enforcement roll up on people, they will know that, look, that's somebody's daughter, that's somebody's son, that we should treat them with dignity and respect. So I am so glad that here in East Baton Rouge Parish, it's required for our law enforcement agencies through BRPD to go through that class and to talk to law enforcement about, what dignity and respect is something that you have to show a person. Everybody who has a mental health diagnosis, we're not crazy. We're just having a bad day, and then also educate, family members that it's okay to call 911 right now. That's the only thing we got. If you can't take your loved one, and take them to the doctor, then that's the only thing you have to do, but it's okay. And look, when you call, ask them for a CIT trained police officer. You have that right to do that. And what that did was that give, family members a peace of mind, because again, depending on what zip code it was, the interaction with law enforcement was going to be different. And so I'm so grateful that we're having this conversation to talk about that. I'm also honored that I get to wake up every day on a mission, because again, I get to share my story of hope. I am a 2-time suicide attempt survivor. The first time I was 13, I end up in a hospital getting my stomach pumped. The next time I was 18 years old, I end up in a mental hospital for 30 days. And again, there was no follow-up. My family didn't talk about it, because in the African American community, you definitely don't talk about mental health. That's those folks' problem. You go to the church, you pray about it, and that's a wrap. Well, let me tell you, the church is the worst. We are. I'm just going to say it. And so because we're not trained to help people in crisis, it's okay. We want to encourage people to love and to pray, and we need to do that. But we also need to let people know the power of refer is real, to refer them out to different agencies so they can get the help that they need. And so being able to do this work and to talk to faith-based communities, share my stories, my lived experience with the African-American community to say, look, there is help. You do not have to be afraid to call that number. And so it's just a blessing to know that 988 is going to help that. It's going to help families. It's going to be a game changer. So when people do know that their loved one is having a mental health crisis, that people who's going to come and engage with them, they know what they're doing. They have the heart, they have the passion, the credentials to help their loved one. So this is truly a game changer for our country. 6 years ago, I ended up having a crisis of myself. Now, how ironic is that? Here I am, a peer support specialist, speaking all over the place, doing all this amazing work, taking care of everybody else, but not myself. Yep. That's how it worked out. My husband and I had some challenges. We've been married for like 24 years at the time, and I end up leaving. And so I went to stay with a friend. And so 6 months into us working everything out, I was ready to come home. And we had a lack of communication that night. I'll use that. And so I remember thinking, you know what, if I failed as a wife, I'm just a failure. And I remember thinking that, Tanja, this is it. Your life doesn't matter. You're a failure. You'll never rebound from this. And so I remember writing a note. I remember getting the medication that I was prescribed and just leaving. And I don't remember too much after that. And so I started getting phone calls from my family members, and I was about to turn my phone off. And I looked down, and it was a friend of mine. She had just lost her best friend to cancer. And I remember, wow, I need to take this call because, she just lost a friend to cancer who wanted to live. I didn't want to live. And I picked up the phone, and she began to talk to me, and she asked me to come to her house. And I'm like, no. And the first thing I told her, if I come to your house, you're going to call the police. And she said, no, I'm not going to call the police. And so after a few conversations, I said, look, I'm going back to the house that I left. And so I went back to the house. And as soon as I made that right turn, there was the police, and that was my nephew. And I'm like, you know what? I got this. I do this all day. I'm a peer counselor. I know how to talk my way out of everything. And so I went up to the police officer, and I began to tell him who I was. And he was like, Miss Miles, we just want to help you. You wrote a note. Your nephew, your family's worried. And I began again to, try to talk myself out of it. And we were having a pretty much decent conversation. And I did ask him, I'm like, are you CIT trained? And he was like, yeah. And I'm like, hey, he's like, I think I know you. And I'm like, yeah, you probably do. And we just started having some great conversation. He's like, Miss Miles, we just want to get you some help. And then I remember about 2 or 3 minutes into the conversation, there were 2 more cars that rolled up. And the other one was an officer who got up, who was smoking a cigarette. And basically he began to just curse at me. And he said, you need to go to the hospital. All this going back and forth is not necessary. Now here's this guy just trying to talk me through a crisis. And so he began to curse, and it got bad real, real quick. And I remember being in the military for 9 years, military police. I'm like, this will be a good way for me to die tonight. Suicide by cop. This will be an easy way out. And as I thought about launching out at him, I looked at, my nephew, and I'm like, this is not something I want him to see, because I know this will traumatize him. So I had enough wherewithal to keep my sense of being present to the police officer who was trained. And so that right there was really, really scary, because it could have went bad so many different ways. I'm not sure if that guy was trained or not, but he treated me like I was a criminal, not that I was someone in crisis. He treated me like a criminal, not in crisis. And so the other guy said, look, we're going to go ahead and we're going to take you to the hospital. You wrote a note. We're not going to let you ride in the back of the police car. We're going to let you go with your nephew, and we're going to follow you. But I remembering, that could have been a big turning point in my life. And you know what I decided, I'm not going to share this story with people, because, what are people going to say? You do all this amazing work and you look like you have this amazing life, but you had an episode 6 years ago and you wanted to kill yourself. And, how is that possible? Well, life happens. crisis happens. And when people are in crisis, they're not criminals, particularly when people are at the worst part of their day. Because I basically said I was just having a bad day, but I was having a bad 6 months. But I'm so grateful that that police officer who was CIT trained was able to redirect me, was able to help me. And the other guy who was truly not trained, that could have been bad on so many different levels. The other thing, guys, is that, you know, working in the prison sector as a volunteer for over 14 years, I've seen so many people who have ended up in East Baton Rouge Parish Prison who had mental health diagnosis. They should have been in treatment, not in jail. So the fact that we're having this great conversation is amazing. We're going to save a lot of lives, and we're going to help a lot of family members, give them the tools and the resources that they need to help keep their family members alive, because it does get better. And I'm living witness, and I'm proof of that. So I'm just super excited about this, and thank you guys for listening.
Excellent. Thanks, Tanja. That was very powerful. Thank you for sharing your story, and thank you for the work that you do. So I'm Ron Bruno, the Executive Director of CIT International, and I'm going to be talking and expanding a little bit on what Dr. Mckeon and what Dr. Goldman were talking about, the different components of a crisis response system. And that's really what it is. We have to look at this as we're reforming crisis response throughout this entire country. We have to look at this at each component. We can't just say we have one thing and think that we're done. We need to look at how a call comes in, where does it go, who's going to respond, what happens, and where can a person be taken if that's the level that it actually needs. And you know, what I'm talking about, realistically, the different components, they are not new. The components have been put into a lot of different reports. So, for example, a lot of nonprofit organizations, federal agencies, and even federal committees. Federal committees like the Interdepartmental Serious Mental Illness Coordinating Committee was one of the committees set up by the 21st Century Cures Act. It is a committee of 10 federal agencies and 14 non-federal subject matter experts that got together to give recommendations to the United States Congress about what are the best moves. How do we coordinate the efforts for effective mental health care in this country? And part of that did include, how do we respond to crisis when people are in crisis throughout our country? And the components that I'm going to be giving to you today and talking to you today are realistically all included into that report, their recommendations by the non-federal members that went to the United States Congress. And as Dr. Mckeon was talking about, not only do we see communities throughout this entire country starting to come together to look at their crisis response system and reform their crisis response systems, but we're seeing Congress actually take action. We're seeing Congress take action with the Suicide Act, which created the 988. Now we have a rival to 911. So if somebody in this country becomes in a crisis situation, they don't have to call 911. They can call 988. And instead of talking to the opening of a criminal justice system, 911, which leads right to the law enforcement, they can talk to a behavioral health care professional to see if they can help out. The 5% setback on the mental health block grant that is actually going to assist in building each of these components that I'm going to be going a little bit more in depth on. We're starting to see action from Congress, from communities to look at the best practices of crisis response. So let's look at the components of crisis response. As you see on the screen, we have a blue line that goes right down the center. That blue line distinctively separates two complete different systems, independent systems. Too many times we think that the resolution is to combine the systems into one. But if we can keep them separate and just make the connections when necessary, that is a much more effective, much more compassionate type of crisis response system. So over on one side, we have 911, which realistically, it represents the public safety system. Over on the other side, we have 988, which reflects crisis lines and the behavioral healthcare system. Now, we know that the majority of calls that go into 911 do not require law enforcement response. With a little bit of training and with some policy put into place, we can already start to divert calls, crisis calls, from that center over into the appropriate system, the behavioral healthcare system. So we need to build a connection between 911 and the crisis lines. So when a call comes into 911, we train our call takers in the emergency communication centers how to triage that call. And if they make the determination that there is not a true actual level of danger, or there is no criminal concern, they do a warm handoff to the crisis line. From the crisis line, they can then do a secondary triage and make a determination whether maybe 911 was wrong, there is a level of danger. Then they can do a warm handoff back. If not, they can actually resolve the call there. As was mentioned, we know that 80-90% of calls that go into a crisis line are resolved at that level, and nobody has to respond out. Now think about that. If we don't have just this little procedure, this little connection between the two systems set up, those 80-90% of calls would require 911 to handle, which means law enforcement would have to respond. But we don't want to just stop there, because we can still even go further in resolving some crises in a telephonic manner. And we do that with the warm line. Warm lines are generally staffed by certified peer specialists. So when a call goes into a crisis line, if they make the determination that it is not an emergent situation, they can hand that off to the warm line. Many times calls go into 911 or go into the crisis line that aren't really emergent. They're not an emergency to deal with right at that moment. What they are, though, is that somebody is needing a little bit of attention. They need some counseling or some resources. Actually, they need an empathetic ear, somebody that might be able to understand what they're going through, and that's where a warm line comes in. But of course, we're not going to resolve everything at a telephonic level. That's why we need to have somebody to respond. Well, over on the 911 side, of course, we have EMS, and we also have law enforcement that can respond out to these types of calls. But the question comes into play is this who we want to respond? And as I finish going through this presentation, I hope that you're looking at this through the eye of, if it was me that was actually having to access the crisis response system, who would I want to have respond? If it was my child or another loved one, who would I want to respond? And that's why more and more communities are starting to step up. That's why the documents that are coming out from ISMIC, from SAMHSA, are supporting non-law enforcement crisis response systems. Now, those teams are made up from different disciplines. If we look at the CAHOOTS model out of Eugene, Oregon, it is made up of a medical personnel tied in with a crisis worker who responds out. And if you look at their numbers, it is in single digits where they actually need law enforcement to respond out in percentage-wise. Other communities, such as Salt Lake City, Utah, or Phoenix, Arizona, they actually utilize a clinician and a certified peer specialist to respond out. Whatever the makeup is, we know that not bringing law enforcement into those types of situations where they are not warranted, the crisis is handled in a different manner. Now, of course, we can't remove law enforcement from all crisis situations. Law enforcement is always going to have a very important role to play in a crisis response system. We just need to make sure that it's defined and that it's warranted when law enforcement does respond. But that's why every single community, as was put forth in the recommendations by the non-federal members in the ISMIC report to Congress, that we need a cadre of officers, patrol officers in every single community that have specialized training, who are screened to be able to take on that mantle of expert to respond out when it really warrants law enforcement response. But we don't have to dismiss the non-law enforcement crisis response team. We dispatch them as well. They show up on the scene together through memorandums of understanding. They know how to work with each other. They know they can share some information. We train law enforcement how to work with that non-law enforcement team. We trained the non-law enforcement team how to work with the specialized police patrol officer, and then they go in and safely handle the situation. And most times when we send out mobile crisis outreach team, the situation is resolved at that level. We don't have to transport anybody. But just like we were not able to resolve every crisis situation telephonically, we're not going to be able to resolve every crisis situation by sending somebody out. So there is times that we will have to take somebody and transport them to another location. Well, we already have the emergency department on one side, the 911 side, but realistically, is that what we want to continue to utilize? The problem with utilizing emergency rooms is their design is realistically to intake, triage, stabilize, and either move them out or hand them off to a specialist. It really isn't the best lineup. It isn't the best model to handle a crisis situation. Crisis needs to be handled in a lot slower manner and a different manner than the ER. Another problem with ERs is that when you start getting into the smaller communities, they may not have immediate access. The emergency room physician may not have immediate access to a mental health professional. And so when somebody does show up in a crisis, they may be dismissed too quick before they really should have been let go. So we do need to be, as was mentioned earlier, we do need to be building further resources. For example, the Crisis Response Center is a fantastic way. Tempe, Arizona has a fantastic model where there's no wrong door. Anybody can be taken there and receive the assistance they need. Now, I know we have rural and we have frontier communities throughout this country, and there's really no way we're going to be able to have a freestanding crisis response center. So we can also look at access centers. Access centers are basically built on the exact same model, but it is part of the hospital system, but it is independent of the emergency rooms. And if we can get even access centers starting to be developed through partnerships with the hospital systems, and if we can get hospital administration to really hold to the fact that not everybody that goes to that access center needs to have pre-screening in the emergency room, that too can help our rural and our frontier locations. You know, when we're talking about reforming crisis response throughout this entire country, we just need to develop and reform crisis response systems that advance behavioral health equity. It needs to ensure that every person has the right to access quality healthcare, regardless of the individual's race, ethnicity, socioeconomic status, insurance status, or geographical location. We need to build and reform crisis response systems that are effective, compassionate, and again, handle the crisis in the least intrusive manner possible. With that, thank you.
Thank you so much to all of our speakers and our panelists today for bringing your expertise to the table and talking about this really important topic. I know we're over time. We do have 2 questions that I think it's important to respond to, but before we end for today. The first question that we're gonna have is, I hear the focus on adults. What are the plans to address the developmental differences for children and families in this? And I think that question should be sent to Dr. Mckeon if he's able to answer that question.
Yeah, I think one thing that's important to be aware of is that 988, like the current suicide prevention lifeline number 1-800-273-TALK, is available for adults. It's available for youth. It's available for family members who may be concerned about a loved one, about a child, or about a spouse. I think that The FCC's action yesterday around texting to 988 is also an effort to make more available modalities like chat and text that youth in particular are much more likely to want to utilize in a crisis than perhaps making a telephone call. So there's really an effort to try to take that into account. And similarly, the mobile crisis systems need to be available for adults and children. Connecticut has a wonderful system. They have an adult system and a child system for their mobile crisis outreach, but it all goes through a single call center to make sure that the child teams or the adult teams are, when needed, are able to get to the people who need to have that service.
Great, thank you. Thank you. We have time for one additional question, and I'm just going to send this question out. It says, what do you recommend states and federal government need to do to help implement the recent congressional action on improving crisis response, like the 3-digit 988 code, the mental health block grant 5% set aside, and the most recent mobile crisis Medicaid funding?
Well, I'm happy to take at least, part of that.
Okay.
Numerous states are really looking at this, which is, I think, exactly what they need to do. Many are considering legislation. 2, Virginia and Utah have passed laws already, who trying to move in this direction of a unified system with 988 as a central access point, and looking at things like the need for developing protocols between 988 and 911, as Ron Bruno talked about. They need to be able to communicate with each other so that these systems develop over time. We get it right. Vibrant, who administers the National Suicide Prevention Lifeline, has also given state planning grants for 988 to each state to help them think through the preparations that they need to have moving forward, particularly for the call centers and for becoming call center hubs.
And I could add just a little more specific on the answer to that question, is that realistically, it's going to take a committee, some type of committee at a state level, actually looking at how to implement legislation, how to actually start to support the communities, generally counties, or the communities, the regions within their state. CIT recommends that there's a CIT committee that sits at the state level. However, that doesn't have to be a CIT committee, just any type of governing body that really focuses in on crisis response and behavioral health care access at the state level and how to support it at the county levels.
Thank you. So that concludes our question and answer session for today. We are running a little bit over, and I know there was some other questions, but we would really like to thank all of our speakers today, especially from the lived experience side of things, from law enforcement, from legislature to data, all of these pieces coming together to really show a well-rounded solution, and also just to provide information on how we disrupt the current pathway for crisis services and what are the opportunities to make things different for individuals in behavioral health crisis, and especially for communities of color. So we thank everyone for joining us today, and thank you for your participation.